So we are going to be talking about a study that we are thinking about doing here. It's not a guaranteed thing, just so you know that. And this study is about using antiretroviral therapy during the acute phase of HIV and adding monoclonal antibodies, the broadly neutralizing antibodies. And so that will be the subject of what we're talking about. So for the outline for tonight, I'm going to go through some announcements, first of all, for the benefit of the group, and then we'll actually review the study. And then I'm going to finish the talk with some polling questions. So we'll have a chance to answer some questions with some of the polls that Zoom lets us use. So first of all, I wanted to just make sure that everybody heard the news about Pat Miglior's partner has passed last week, I believe it was. And I just thought you would all like to know that. If you're friends with Pat, you might want to reach out to her. I'm sure she's not in a good spot right now. And so I'm sure any of the support that we might be able to give her would be much, much appreciated. So I wanted to first start off with that. I don't have any news about any memorial service or anything like that. I don't know if anyone else here on the call knows anything.
I do.
Not yet.
Oh, go ahead.
Yeah, she's working on that right now.
Okay.
And she's got a lot of support. So, but it's been really hard for her. So.
Yes, of course.
Yeah.
Yes. Well, thank you for sharing that. And if when I get word of that, if you're interested, I will share that information with you all. But definitely, it was a shocking bit of news for me to hear. And then moving on, one of the things, if you remember at our last meeting, we were talking about that we were going to have these new procedures because we were having to identify people and make sure that we could verify their identity and their age. It was a way of checking that no one co-enrolled into a study. Well, we do have that procedures now. So if you are attending our clinic as a participant, we're going to be asking for ID, and we'll take a photocopy of that ID and we'll store it in your chart. And that way, every meeting, every visit that you have, we're supposed to be verifying that you are who you say you are. And so we figured if we had a photocopy of your ID, we'd just be able to flip it open and say, is that you? Yes, that's you. And then just be done with it. If someone doesn't have an ID, what we will be doing is taking a photo of them and then writing their name and their birthday on that photo, and then basically making a copy of that photo and then putting that in the chart. We'll have the person sign it, and then we'll be checking up on this. We will update the photo every 3 years, and we'll check every once per year to make sure that the ID is still up to date and that there've not been any changes, especially in your looks or things like that. So this is something that the Department of AIDS or the Division of AIDS is making us do. And so this we figured would be the least invasive way to be able to say that every visit we're confirming and verifying people's IDs. So that's something that'll be changing in terms of our standard operations going forward.
When does that go in effect?
It goes in effect tomorrow.
Oh, great.
Are you talking about the whole hospital? Or
no, we're talking about
no.
just
No, we're talking about the ACTU.
Yeah, just at the ACTU, just the
hospital currently does ask for ID. So they have something that is more stringent than what we do.
Right. And we're just trying to make it as least invasive and as quickly done as possible.
Well, on studies, are we still just going to be a number then?
Yes. This has nothing to do about your identification beyond that. This is just to make sure that for every visit that we are confirming that you are who you say you are. Yeah, I know it sounds
it seems kind of dopey, but apparently what I understand is that there have been, both in the US and internationally, people who have enrolled in the same study twice or pretend. Wow. So, yeah.
Yeah, and so we don't really have that problem here since we're the only site that does ACTG studies, but for some place like in Manhattan, they have 3 different sites. And so you could see where for some places this might be a little bit more important than others, but nonetheless, you don't have to worry about this being sort of identifying with anything related to the study. It is really just a check for the visits that you have, just making sure that you are who you say you are. And it could be that, you might have a different clinician for one visit and they might not have ever met you. So it is something that, a way to make sure that everyone gets familiar with everyone. So there is that little benefit. The other thing I wanted to bring up with you, remember we were talking about creating a new name for the clinic. And we had those meetings a while back. Well, we do have a new name now. So the new name would be UW Positive Research. And it has been approved by the School of Medicine. All the deans of the School of Medicine had to review it. And Rachel, our director, went through and had to go through a whole process of applying for this. But this will be the name. The actual name change is going to be taking a little bit longer while. We're looking at doing something public in the late spring to celebrate this and to mark the transition. This name was gone. We went with this name mostly because we thought Positive still kept a tie with HIV specifically, but it also fit the other types of research that we do, since we're also doing Hep B and Hep C research. We're also doing COVID research. And so the Positive could be meaning many other things that way. And so this is the name that we have decided to go with and that we got approval from the UW for.
Now, with the new name and with the Google search, is it gonna pull up that, or is it gonna just continue to see for a while the previous name?
Well, for the time being, it's going to be the previous name until we start that transition. So there's a lot of things that need to be changed and addressed, and I'm not sure exactly how those changes will be effective.
Okay.
In other words, for instance, our website is uwactu.org or .com. I don't know if changing it will be as easy as just creating a new name and creating a new URL for it. But that's the sort of stuff that we're going to be investigating. That's why we're pushing off any sort of official announcement about it until late spring to give us time to transition. I have a Facebook page and a Twitter account that I have to worry about new names for, all of that sort of stuff.
Yeah.
So it'll be a slow process of, slowly changing those things, but I'm hoping that it will be something that none of you ever have to experience a hiccup. In other words, that we can do this all behind the scenes, so to speak, and just change the things, but none of that will affect the contacts that we already have.
Yeah, well, hopefully you got text that can figure it out to where when you put in the old name, it'll automatically link you to this new
Yeah.
site.
That's the plan.
Yes.
And because there are a bunch of grants that are in the ACTU name, and we don't want to use the words, but the ACTU part is pretty well known and is sort of been part of what needs to stay for at least a while.
Yes.
Yeah.
So just a heads up to you all that this is the name that we'll be going with forward, and you might start seeing a new logo, for instance, or you might start seeing changes with the Facebook page, or if you follow us on Twitter, the Twitter account. But I want you all to know that. Other things that are exciting to know. We have the Community HIV Cure Research Workshop coming up, and the first session is going to be on February 8th, and you are all invited to join that. And in the chat, I'm putting the information. So you'll see in the chat that there's the link to register for session 1 as well as for session 2. Session 1 is February 8th, and we'll be talking about lots of different things. We're going to be talking about ethics related to cure research. We're going to be talking about the Esperanza patient, and we're going to be talking about HIV cure research terminology that is problematic and trying to get community feedback on the analogies and the terms that people use to describe things that are related to cure. The second part, one of the big things that will be happening in March is that we will give you some direct feedback about cure-related science that was presented at the CROI conference that will be happening in between these two sessions. We'll have 3 different scientists telling you what science they thought was really important or unique or exciting, and that'll be an exciting part to go through with session 2. You can register for one or you can register for both. And if you want, you can also follow the Facebook event page, because I'm putting up lots of articles and stuff that are related to the topics that will be talked about at each session. So focusing right now on the February 8th, which is about 2 weeks from now. And I would really appreciate seeing you all there, since I'll be one of the co-hosts for this event. Gary's coming back. All right. So, and there's session 2. Sorry, I should have gotten there. So talking about the study, before we even get into that, I just want to make sure that everyone kind of realizes that number one, we know that antiretroviral therapy works for HIV. It helps to reduce the deaths related to HIV. It helps reduce the sicknesses that are related to HIV. And it does that by stopping HIV's replication cycle. It's the 3 different drugs that people have to take actually stops the replication and keeps it suppressed. However, antiretroviral therapy is not perfect. For instance, it does not eradicate the virus. And when people go off medicines, usually they have a viral rebound within weeks. It doesn't restore the health, and that we know people with HIV still experience non-AIDS conditions greater than the general population. So for instance, cardiovascular disease and certain cancers seem to affect people living with HIV more. And also there are lots of barriers to universal use. It's been over 20 some years now that we've had antiretroviral therapy, and we still haven't been able to get everyone on medicines. There are toxicities that we have concerns about. There's the cost related to antiretroviral therapy, drug resistance that makes people sort of get to the end of their rope, that they have to worry about that. Taking pills every day, that lifelong adherence is just unfeasible. And of course, there's the stigma related to HIV and HIV medicines. And so there are lots of problems that really face antiretroviral therapy as a treatment. And so we need new treatment strategies that will minimize the ART exposure and yet still confer that durable virologic control and delay any progression of disease. If we could find treatments like that, they would be highly desirable. And so this study is one of the attempts at finding something like that. So the study's number is 5388. And the title officially is a randomized clinical trial of combination HIV-specific broadly neutralizing monoclonal antibodies combined with ART initiation during acute HIV infection to induce HIV remission. So you can kind of see there, I did the dual colors there to show you the 2 different parts of the study that we'll be focusing on. Broadly neutralizing antibodies combined with starting antiretroviral therapy during the acute HIV infection phase. So we know that starting antiretrovirals during early HIV, catching it very early, is beneficial in many ways. It leads to a smaller latent reservoir of HIV. It can also reduce the viral diversity because you're stopping the replication of the virus early on. And it can actually help you preserve the innate immunity that you have. And so innate immunity is what you are sort of born with, as opposed to the adaptive immunity that happens as you experience different pathogens. But it can also preserve the T cell and the B cell responses, which is a part of that adaptive immunity. So we know that starting ART early is beneficial. And that's why you may have seen here in Seattle and in King County, we try to get people started right away on medicine. When we find out that they have acquired HIV and they've tested positive, we try to start them the same day if we can. Now, some people who started ART early showed a delay rebound after stopping. So for whatever reason, they've taken ART for a while and then they have stopped. And some of them seem to control the virus when they go off meds. They still keep control of the virus, like they still keep it suppressed. And it's anywhere from 5% to 16%. Different studies have shown us different numbers like that. But some people start medicine and then stop, and they seem to still control the virus. The most famous of this was the Visconti Cohort, which is a group of people, men and women in France, who stopped their ART, and about 15% of them are still controlling the virus for over 5 years. And that's really remarkable compared to the people who spontaneously seem to control HIV, which is basically less than 1% of the HIV population. And so you might know these as 2 different names. So we call people who go on treatment and then stop and yet still control HIV, we call them post-treatment controllers. And the other group over there are the elite controllers, those people who never go on medicine because for whatever reasons, they seem to be able to control the virus without needing ART. So elite controllers are before ART and the post-treatment controllers are after ART. there's one other type of controller that I do want to introduce you to, although we're not going to focus on them much tonight, are the exceptional elite controllers. And there are two women so far who fit this category. One is called the San Francisco patient, and the other one was called the Esperanza patient. And these are women who, for whatever reason, have HIV, but where HIV has embedded itself in their DNA, it's in a sort of dead zone. And so the virus doesn't replicate. So they do have HIV, but they're controlling it exceptionally well. In fact, the San Francisco patient came out about 2 years ago, and her name is Laureen Willenberg. And you can read her story if you look up her name. And more recently, the Esperanza patient, the news happened. And if you're interested in learning more about her, you can come to us for the HIV Cure Research Workshop, because we're going to be talking to the scientists that have worked on her specific case, and you'll be able to ask questions of them about this unique, exceptional elite controller situation. So just wanted to review those, but there are certain factors that are associated with post-treatment control so far that we can deduce. And one is that they have basically a shorter duration between HIV onset and starting ART. So there's not as long of a distance. They didn't wait for a year or 2 years. They started relatively in a quicker fashion. The other is that they have lower levels of the HIV DNA in the blood. And the other factor is that they spend a longer duration on ART. This combination seems to be involved in having people become post-treatment controllers. It's not the only factors. We're still trying to deduce those. And just as a caveat to everybody, this is by no means giving you sort of a carte blanche to take yourself off antiretroviral therapy and see what happens. Please do not think about doing that. So we have early ART, and then we also have in this study broadly neutralizing antibodies. And here we have an artist's rendering of what those look like. So those green Y-shaped squigglies are the antibodies, and the purple flowery looking thing is the HIV virus. And so how these antibodies work? Well, the bNAb attaches to a specific area on the surface of the virus on one of those spokes. And basically the tail part of that Y then signals to the immune system, and the immune system gets involved, and it leads to the death of the cell and the clearance of the cell. So those antibodies attach to those spokes and basically neutralize HIV. Now, we believe that there are several potential advantages over ART that could promote HIV control. So the first one is that it seems like these broadly neutralizing antibodies can help reduce the viral load. And in fact, if you use them in combination, so if you use more than one type of bNAb, you have a greater reduction in viral load compared to just using one bNAb. So we know that it can reduce the viral load really well. It can actually help drain the reservoirs. So it inhibits the viral replication from reactivating. And so the reservoir can't reactivate. And so it helps as you're clearing the virus, then you're sort of draining that reservoir of the virus. And this thing is the new term that I really love, a vaccinal effect. So bNAbs can have an effect that's like taking a vaccine. So it seems that when we give bNAbs to people, it can increase their immune responses to HIV, as if you were getting a vaccine. And you know how vaccines boost your immune system's ability to recognize pathogens. And so these bNAbs seem to act that way. So because of these three factors, we think that there would be some potential advantages over using just ART to help promote HIV control.
Is this in combination with the HIV medication, or is this bNAbs just on their own?
This is just bNAbs on their own. So what we're actually doing in the study is trying to use bNAbs plus ART. As you can see, like it's like, oh, well, we have bNAbs which seem to be effective against HIV, and put them along with ART, which we know is effective against HIV. Hopefully we'll see some sort of doubling of power and maybe be able to create situations like post-treatment control for people.
Okay, and this is on your website?
Not yet. We haven't decided to do this study yet. So
okay.
That's why we're reviewing it tonight, to get your opinions about should we do this or not.
Okay.
So just to review, there's two different ways that people might be given bNAbs: through an infusion, which would be through the arm or a vaccination. And so the infusion is directly giving people BNAbs. And these are able to neutralize most types of HIV. And it sort of gives an instant protection that lasts for months. And in fact, we've seen infusions being used in prevention with the AMP studies that were going on. But also, we can do this through vaccination. In other words, you're giving someone a more traditional approach that's going to stimulate the body to make these BNAbs and create the immune responses. It usually requires 2 or 3 immunizations to stimulate protective immunity, but it can provide a long-lasting protection. So what we're talking about in this study, however, will be infusions. We're going to be giving people infusions of antibodies. So vaccination is just one of the other ways it's done, but I wanted to let you know that those are 2 of the different ways that we're looking at broadly neutralizing antibodies for people who are living with HIV. So the design of this study, it's a phase 2, 2-arm, randomized, double-blinded, placebo-controlled study. Now that's a lot of adjectives describing that study. Do we want to unpack this? What does it mean that we're randomizing? Anyone can shout it out.
It means that you're going to go in one of two parts of the study.
You got it. So you got it.
You're going to get the medication or you're going to get the placebo.
You got it. It's a placebo-controlled study, so you're going to be randomized, meaning like flipping a coin. You're going to flip a coin. And,
chance, yeah.
Right. It's flipping a coin. It's up to chance. That way, we're not sort of loading up the study to have certain benefits. We're just trying to keep it as randomized as possible. It's double-blinded, meaning that the person who's participating in the study won't know what they're getting, nor will the clinicians who are giving them the medication know. So neither of us will know who's getting what. And we are enrolling adults with acute HIV infection, or AHI, who have not yet started ART. So we're looking for a total of 48 participants for this study. And they're going to be randomized in a 2-to-1 ratio. So for every 2 people who are getting the medicine, there'll be 1 person on placebo. So we'll actually end up having 32 participants on medicine and 12 on the placebo. And so the first arm is going to be the arm. We're actually giving 2 different antibodies, and I've given you the sort of names for them right now, which are just lovely to try to say. VRC07 523LS and PTG121.BIJ414LS plus ART. So they'll be getting 2 antibodies plus ART. And in the other arm, they'll be getting the placebo, which is just a saline solution, plus ART.
Can I ask a question?
Yes, you may.
Do they know how many people in Seattle, say on a monthly basis, contract HIV?
You know, they might not know that, but one of the things I was going to be talking about a little bit later is why we might be a good site to do this study, because we've done a previous study where we had to enroll people who were in that acute HIV phase. So basically trying to get them within the first 30 days of HIV infection. And we did a pretty good job of doing that. Okay. So we might be, with all of the sort of networking that we've put in place around trying to catch people very early. In general, in King County, we do a good job of catching people's infection early, because we do testing where we give them the antibody test, which is like a finger prick or a mouth swab, but we also get blood from their arm to do basically a viral load test. And so often when the antibody test comes back negative, but the blood from the arm comes back positive, we know that that person has recently acquired HIV and their body has yet to start making the antibodies that would make that finger prick or that mouth swab come back positive. So they're usually within that early phase. So that's how we can identify them very easily.
Okay.
But in terms of numbers, I'm not sure. We can look that up though. So going on. So we have the first arm, and they're going to get the antibody infusion on the first day that they enroll. And the reason that they're doing that is that they want to sustain the antibody levels throughout the anticipated period of acute viremia. In other words, if you remember, when people first are infected, HIV seems to go way high, up into the millions of copies sometimes, and then comes down to a set point, and then we start the sort of long, slow haul through that. So we want to make sure that they have antibodies during that period, but we also want to make sure that they clear the antibodies from their blood prior to beginning the analytic treatment interruption, which is planned at the end of this study, or not the end of the study, but in the middle of the study at week 48. So they'll be on this treatment, ART plus the 2 monoclonal antibodies, for about a year. In the second arm, they would start the placebo at the same time. So the very first day they enroll, they'll be getting that, and they'll be starting ART. And this will just be normal saline infusions, and they're on that for 48 weeks, and then they go on to an ATI. Both groups will be provided ART at enrollment, and about 4 hours after the infusion, they'll start their ART, and they're being given Biktarvy, which is an integrase inhibitor. It's one of the newer medicines. It's a single tablet with 3 different medicines in it, and it seems to work really well at getting people to undetectable levels very quickly. So they will be given this for the study as well. So placebo or the 2 antibodies, and then 4 hours later, they start Biktarvy.
Michael,
Yes.
how will they ensure the clearance of the BNAbs without unblinding the study?
That's a good question. So they will be doing a large blood draw. Let me get to the next slide and I'll show you. So they are planning on, at week 44, so 4 weeks before the ATI is supposed to start, participants are supposed to undergo a large blood draw or an optional leukapheresis, which will be looking at that. So I don't know exactly what will be happening, but that's a good question to ask the study team. I'll write that down. I'm not sure exactly how they would be able to recognize that there might be BNAbs still in the system and yet not unintentionally unblind someone.
And are they, and I assume they'll be doing the same process, whether people are in the placebo group
Yes.
or the other group, right?
Yes, yes.
Looking
So,
for the antibodies.
right, both arms at week 44, they'll either have a large blood draw or they can do an optional leukapheresis. The leukapheresis takes a little bit longer, but that's having a machine collect the blood. It'll take about 3 hours for that process, they say. But that's 4 weeks before the ATI. And then if participants are undetectable, so they have an HIV RNA at less than 50 copies, they can begin the ATI at week 48. And after that, every 2 weeks, they will be monitored and they'll be taking their viral load as well as their CD4 count. And the ATI is scheduled to go up to 24 weeks. So ART will be restarted during the ATI if they have a viral load greater than 1,000 copies 2 times, 4 weeks apart. So in other words, they may have 1,000 copies at one visit. 2 weeks later, if they have over 1,000 still, ATI will be, the ART will be restarted. If their CD4 count goes below 350, they will be restarted. If they have any sort of acute retroviral syndrome, which is a good sign that HIV is coming back, they'll be restarted. If there's any sort of clinical disease that progresses and is noticed, we will restart. If they become pregnant during the study, that we will restart, or by the participant's request. They can just request to be restarted, or their provider could also request that. So these are some of the restart criteria that will take someone back onto ART. Participants who do not meet the resumption criteria will continue past the 24 weeks, and they'll be monitored every 4 weeks after that for another 96 weeks. So people who don't have a rebound or don't have a reason to restart can continue on even longer if we manage to create that situation, which is what we're looking to see will happen, which is called HIV control. And so I was going to say it could be up to 216 weeks that they go through this. Go ahead. What was your question?
I was going to ask how often the viral load is being monitored. I see you have, if 4 weeks apart, if they have 1,000 copies, you're going to restart them. But
So
are,
before that,
are you, I would assume you're monitoring viral load more frequently than that and
so for
at
the
the
first,
beginning of the interruption?
yeah, so for the first 24 weeks, they're getting it every 2 weeks.
Every 2 weeks.
Every 2
And-
weeks for the first 24 weeks. If they are still having no sort of viral rebound after the 24 weeks, they will then go on and they will be every month then.
Has there been any thought to trying one of those like home things that you can leave attached to your arm for self-monitoring in between?
I
I don't know where those devices are at and approval
Right.
or anything.
But I will write that question down because that's also a good question about home testing. I don't know if they've thought about that or if they even have access to anything like that. I know certain groups that are doing studies that are actually studying that device have access to it, but I don't know if it's yet ready for prime time.
Yeah, okay.
Yeah. So again, they can go on for up to 216 weeks with this.
So Karine just said something.
Go ahead, Karine.
Yeah, I think they're still testing the reliability of the home-based viral load testing to detect viral loads, the sensitivity of the test. No results yet. I think they're batching all the results. Hopefully it will be available later this year. And I think you're doing a wonderful job, Michael, explaining those protocols.
Oh, thank you. So now during the ATI, remember there's some concerns that we have not only about the participants' health, but the fact that if they have a viral load, they might be able to transmit HIV to uninfected sexual partners, especially if they're not using condoms or if their partners aren't on PrEP. So that's a big concern. And so given these concerns, the study has plans to restart people immediately if they report condomless sex with partners who are HIV negative or unknown HIV status. Also, they're going to restart if a participant shows up and they have a sexually transmitted infection like chlamydia or gonorrhea, which is obviously evidence of condomless sex happening. So those are some of the restart criteria that weren't mentioned in the previous slide.
If they're having condomless sex and their partners on PrEP, will you keep them on?
Yes. That's what the protocol says, yes. So it's only if they're HIV negative and not on PrEP, or if they are HIV unknown status. So you can see here's a sort of visualization for you of the study design. So that first part that's in the sort of tan background, people will start, they get the infusions and they start their the Biktarvy, and they go for 48 weeks. So for a whole year taking Biktarvy, but they only get the infusion once. So 4 weeks before the planned ATI, they have a leukapheresis or a large volume blood draw. And then if they are undetectable at week 48, they start their ATI and we get to see what happens. And so if they make it to 72 weeks or 24 weeks out into it and everything's still good, they can get an extended ATI. And
what happens if someone decides not to either not to begin or continue with their ATI at that point?
They are allowed to restart at any time, and then we follow them for another 48 weeks.
Okay.
So if they're halfway through, and even though HIV hasn't come back, but they're just feeling anxious and they want to go back on ART, that's totally fine. Go ahead.
Yeah, and I assume you'd be tracking that in your intention to treat analysis, right? How many people chose to not do it right? Yeah.
Yes.
Okay.
And Kate, you had your hand up?
Yeah, on the previous slide where you were talking about if their counts are 1,000 and then you'd retest them and they're 1,000 and you would immediately put them back on the ART. And
Yes.
that you had said, well, pregnancy or participation request to drop.
Yes.
How is that going to affect the study if you have people within that study that decide halfway through to drop out because they're getting pregnant or because they just don't want to participate anymore?
Well, obviously, it might not prove our case. In other words, if people are doing well, and let's say they went to the 18th week on their ART, but they just couldn't handle it anymore, obviously, we're not getting to our full endpoint. So it may affect the data, but we're still getting lots of information from their participation, including facts about the design of the study. So in other words, if a 24-week ART break is too much for people, maybe we'll find out that it was too long, like 24 weeks was just too long and people were really not able to psychologically deal with it and wanted to go back because they felt better on ART. That's sort of stuff that we'll learn from the study as well.
Okay, I'm just kind of curious how that would affect the study and if it would, in the long haul, put a stop on the study.
I'm sure it could really affect the study that drastically if like a lot of the people did, but that's one of the things that would be talked about at the beginning of this. Like, so in other words, when people are enrolling in the study, one of the criteria is that they have to be willing to go on an analytic treatment interruption.
Okay.
You know, but we're still giving them the out. And, you know, of course, anyone who gets involved in any study is always free to withdraw from the study for whatever reason. You know what I mean? Like, so that is, every study has that sort of feature to it. But they could still be in this study and just request to be put back on ART and still followed. They would still be part of the study. It's not like they would discontinue it. They could choose that as well. So
that was just one of my concerns, because I know this is a study that is fairly new, and it could probably change the way HIV is being treated.
Yeah.
And it would just be a shame to see it go to the wayside because people are getting involved and then just can't deal with the long participation of the study.
I agree with you. That would really be a shame. But again, if the study is asking too much of people, that's one of the ways they would quickly figure that out. And it might be possible within the conduct of the study that slight adjustments might be able to be made to help people stay in the study.
Okay.
You know, that's always a possibility. Again, it's just really, we'll see how it is in terms of enrolling it and conducting the study, what actually happens.
Yeah, and they've probably figured out how much dropout they might be able to tolerate and still have a result. At what point, you know, it's like kind of like at what point do you hit futility where you can't answer the question?
Right.
But assuming that most people would follow the protocol, you should still be able to answer your question.
Yeah. So, and that's why
if it makes a significant difference.
Right. And so one of the things I wanted to point out to you on this slide, oh, is it on this one? Maybe it's not. So, oh yeah, well, so you can see there is a chance for people to actually continue on if they reach that second extended ATI and they reach the end point of that and they're still not having a viral rebound, they could potentially be sort of co-enrolled into that other study. If you remember, we talked about it a few months ago, where we have a study that will just be observing people who might be on an ATI and wish to continue with that. And so they would just go into this other study, which number is 5385, and they could still be followed up that way through that study.
So that's not shown there because it looks like everybody there goes back on ART.
On ART, yeah. So, you know, so participants who do not meet the resumption criteria at the completion of step 2, they can proceed to step 3 for continued monitoring, and this step could be adapted to follow up in this other study. So that's what they're saying there for that. So there is, you know, in other words, if someone's having post-treatment control and they're doing well and they're still continuing controlling their HIV and they don't want to go back on medicines, we'll have a way for those people to continue on and yet still be followed. You know, so trying to meet all those situations of what should happen. So the hypotheses that are fueling this study, they believe that the administration of giving these BNABs with ART during the acute HIV phase will be safe. So that's the first hypothesis. They also believe that participants who are getting the combination therapy in addition to ART will be more likely to demonstrate suppression at the 72-week mark, 24 weeks after the treatment interruption, as compared to participants who just got the placebo plus ART. So they're saying that this is more likely. That's one of the things that we're basically hoping to answer, because if we can create these post-treatment control phases, it would help people not have to stay on ART as long.
What exactly are BNABs?
BNAbs are antibodies that are made in labs based on antibodies that they found in people who were living with HIV for a while. And so their body got to creating antibodies that could address many different types of HIV strains. And so their antibodies were broadly neutralizing. They weren't specific, they were broadly neutralizing.
Okay.
So these are antibodies that are made in the lab, and then they're cloned, and you make a lot of the copies of the same antibody. So the other hypothesis is that the people who are going to get the combination BNAb therapy, in addition to ART, will demonstrate lower viral reservoirs and enhanced specific HIV-specific immunity at the completion of the infusions as compared to participants who only receive ART. So they're hoping to see that the viral reservoirs have been made smaller before they go on before they go on the ATI, excuse me. So now the feasibility is something that Bill was bringing up and asking about in terms of like how many people here in King County do we have? So in general, the ACTG has demonstrated that it can enroll these people who are in the acute phase. So we did a previous study, it was called the early study, and it was looking for 3 different groups of participants with early HIV infection. And we basically started them on ART as part of the protocol. And it was done domestically, mostly with US sites. And we were one of those sites. So we enrolled as a group participants during the first 2 phases, the FIBIG stages. We got 49 people. The next 2 stages, which are FIBIG 3 and 4, we had 79. And FIBIG 5, we got 60 participants. And this was all of the different sites around the ACTG. I think locally we screened about 9 people and we had 5 people enrolled. So we've demonstrated that we can do this. And the study demonstrated that the ACTG can identify these people and enroll them and treat them during during AHI, during the acute phase. And so this study is going to involve the sites that participated in that previous study, so we can take advantage of all of the screening mechanisms that have already been identified and field tested to enroll this difficult to recruit population. So for instance, we had a whole system of phone calls. So when someone through public health may have tested and had an antibody test that was negative, but a viral load test that came back positive, we had a whole system in place, phone calls, and people just went into high alert and dropped what they were doing to make sure that we could try to enroll this person that day. So we've proven that we could do it. So that would make us a site that would be able to do this new study because we've proven that we can find people with acute HIV infection. So it would be feasible for us to do it. So here's the inclusion criteria for the study. This is things that people need to show. Well, first of all, people need to be between age 18 and 70. And the reason that 70 is the cutoff is because after that, we have concerns about the immune system not being as effective for people. And so they cut it off at 70, which I know is often a sore spot for a lot of people in our community. Participants who are engaging in sexual activity that could lead to pregnancy must agree to use condoms while receiving the antibodies and for 9 months after the last antibody dosing, which is actually at the beginning of the study. And that's to avoid pregnancy in a partner who's assigned female at birth who is of reproductive potential. Did someone have a question?
No, I just.
How many of the people that you enrolled completed the study?
With the previous study that we were talking about?
Yes.
That's a good question. I didn't ask that. So I know that we had 5 people enrolled. I think most of them completed the study.
I think that's right, Michael. I think that's right.
I'm not sure. Go ahead. There was another question?
Yeah, if somebody has a steady partner and their partner agrees to use PrEP, can that person not agree to use condoms?
Good question. I will ask that.
That's a great question, Lori.
Yeah, I didn't think about that. And I hadn't seen anything in the protocol about that. In fact, you know what? I forgot. I wanted to send you all the protocol. So hold on. I'm going to do that right now. If you look in the chat feature, we'll have the community copy of the study here so you can all have it. So it'll be loaded up in a moment. And please feel free to download that. So you should see it in the chat now.
So how do you download it, Michael?
You should be able to just click on it and it should download for you.
It just disappeared.
It disappeared?
It disappeared.
You're
Did it
gonna
just-
send us all this information through our emails, correct?
I can send this through email as well, but let me try this one more. It should,
I mean, it was there for a minute.
did it disappear for everybody?
Now, now it's
I
back.
got it.
Yeah,
Okay.
it worked for me.
Okay, so there you should be able to see this protocol and look at it for yourselves. I meant to send that out earlier. I apologize for forgetting about it. So back to the enrollment criteria. So they have to be willing to start ART at the enrollment. So the first day of the study, they will be starting ART. They cannot have any use of ART for any reason within 60 days prior to the study entry. So in other words, they could not be on PrEP and then become positive. That will not be allowed. There's no active hepatitis B or C infection, no recent serious illness or a condition that required hospitalization, and they need to be low to moderate risk for heart disease. And they have to express that they're willing to participate in the ATI. So there's lots of exclusion criteria. The first one is if they've previously received an immunoglobulin therapy. So this could be a prophylactic therapy for hepatitis B or for rabies. And they can't have any of that for 12 months prior to the study screening. Or if they have that 12 months, more than 12 months, they won't be excluded. So they can have had this for prophylactic therapy, but for any other reason, they could not have it.
Do you think it's a problem that they wouldn't be able to be on PrEP?
I think it's a problem. What does other people think?
I think it's going to lower your pool of candidates significantly.
I think so too.
Because if you're not going to be on PrEP and you're being sexually active to the point where you can become positive, you're probably not going to be willing to do a study anyway. I mean, you know what I mean? I think there's that whole process there, but
I agree.
Yeah, no, I agree. That's why I asked the question, because it seems pretty weird to, because I think that people who are likely to be interested are also likely, if they have access to it,
right,
want to be on PrEP.
Right.
If they're, depending on how sexual they are, they might not have enough sexual activity to warrant being on PrEP.
Right. It will, I think, limit the pool,
And-
will it limit to the point where we can't enroll? I don't know.
And if somebody's gotten injectable PrEP, is it still the same timeline for, say, your last injection? Would you use the 60 days, or would it, given the long tail they've talked about, would that need to be longer?
Exactly.
And are they wanting that to all be washed out? Are they wanting people to be naive to these medications? Like, what are they really trying to get to by not having somebody be on PrEP?
I think they're trying to make a perfect scenario where they can't say, well, this person had an additional boost because they were on some sort of antiretroviral therapy for PrEP. In other words, they're trying to make it, they were never on any sort of PrEP agent, no prophylactic agent for HIV, because that might stack the deck.
It could also, it would also potentially confuse the timeline as to when they became or when they started seroconversion or when they actually acquired HIV.
Exactly, because we know that taking PrEP can delay the onset of HIV. And we've had some cases where they couldn't really tell if they were positive or not. They couldn't really tell if seroconversion had happened, and they had to actually stop PrEP before they could actually see that HIV did come back.
I think it's going to lower your pool, but I don't think it's going to create it to where you're going to stop the study altogether, especially if you link with the other agencies that you were talking about previously.
Right.
I think you'll be able to get the population that you're trying to target but I think with previous people being on PrEP, trying not to become positive, I think that is going to limit your amount of people that are going to be available for the study.
I think that will as well. We'll see. You can't have a history of any sort of severe allergic reactions or have a history of chronic hives that require some sort of daily treatment. I love this. No receipt of an investigational agent within 28 days prior to enrollment. So if you were in another study that was doing some sort of investigation of a new agent, within 28 days, you cannot enroll. If you have past participation in an investigational study of a candidate HIV vaccine study or an immune prophylaxis for HIV with receipt of an active product. So in other words, if you were involved in a study like this, but you had the placebo, you would still be able to enroll. But if you got an active agent, you're not allowed to enroll.
If you are able to know that.
Yes, that's another good point with the unblinded or versus being blinded.
And what about the COVID issue? Somebody asked about it, and it just seems like, I mean, does an EUA count as investigational?
I don't know. That's a good question. I'll write all of these down. Thank you for all these great questions, because I can't answer them, but that's what we want to do this for, because this is going right directly to the community representative who will take this to the study team and get answers for us.
And
another question is, if somebody becomes COVID positive or Omicron or one of the other variants, is that going to stop them from being in the study? Because with COVID being out there and being prevalent, and you have these people that are just HIV positive, just starting medications, their immune system would already be out of whack to begin with, right?
Right. And so I'm not sure. It depends on if they're getting a treatment for COVID. And I don't know about vaccines for COVID, if that falls within any of these exclusion criteria.
So that's what he's going to ask about.
Yeah, that's what I'm going to ask. So it could be like if you were in a COVID vaccine study, like there's a new, study for a new vaccine, that's a study candidate. That's an investigational study agent. And so if you got the active version of that, you wouldn't be able to enroll. And I'm sure like if you are double blinded and you don't know if you got it, that would probably they would have to assume that you got an active agent. They couldn't go ahead and probably enroll you anyway. So if you have an active or a recent non-HIV associated malignancy that required some sort of systemic chemotherapy or surgery in the preceding 36 months, so for the preceding 3 years, or if you're expected to have some sort of therapy like that in the 12 months following entering the study, that would exclude you. Now, minor surgical removal of localized skin cancers are not exclusionary. So that would be one of the differences there. If you have a history of use of any medications that could have some sort of immune modulatory effect within 6 months of study entry. So you can see all of these different types of drugs. If you have any of those, that would exclude you from the study. And use of antiretroviral therapy for any reason, including pre or post-exposure prophylaxis within 60 days prior to the study. I think we saw that in the sort of inclusion criteria, but just reiterating it. So for any reason, whether it was for pre-exposure or post-exposure. Active drug or alcohol use or dependence that, in the opinion of the site investigator, would interfere with adherence to the study requirements, that would exclude you. Any acute or chronic or recent or clinically significant medical condition that, in the opinion of the site investigator, would interfere with your adherence to the requirements or jeopardize your safety. So that, again, would be a judgment call for the site investigator. If you have a score greater than 10% on the cardiovascular disease scale, would exclude you. Breastfeeding or being pregnant would exclude you. And if you have a weight of 115 kilograms, does anyone know what pounds that is? What's that weight in pounds? Well, I figured it out.
250.
You got it. Is that Michael? Good job.
Yeah.
Yes, here's the actual calculation, 253.532 pounds. So if you were over 250 pounds, that would be an exclusion for the study.
So Michael,
Yes,
where it said drugs and alcohol,
yes.
or dependencies, does that
Mhm.
also include marijuana? Because a lot of people that are HIV positive,
Use
or
it.
that even don't know, a lot of people that don't even know their status do use it.
Right.
So
Um,
now that it's legal, you got more and more people that are openly using it. So is that one of the things that are gonna, they're not gonna be in the study because of something like that?
Kate, I can't answer you, but that's what I love about it. It's a great question to ask because they don't really say anything that's about cannabis. So it just says alcohol or drug use or dependence that, in the opinion of the site investigator, would interfere with your adherence to the study. So I'll ask that though. Would that include cannabis or marijuana? And I'll.
I think the answer is yes, it would. And then the issue is really, is it going to interfere with adherence? Or if someone just uses, they may still be able to adhere to the study if they're willing to.
Right. Yeah. I mean, I don't think cannabis use would be as creating such an erratic lifestyle, for instance, as perhaps crystal meth or some other drugs, where people could disappear for days and forget to take their medicine and all of that sort of stuff.
Yeah, but marijuana is still considered a drug to a lot of health people. So
that's why I think it's a great question. I think it's a wonderful question that you asked. Let me see. I see. Is it the exclusion for previous monoclonal antibodies also a blanket out any history of receipt specifically of targeting HIV? I think it's any antibodies is what they were saying. Is there a time use on or any past? These are good questions, Michael. I will find out for you. All right, and let's see. I'm just looking at the questions that other people have put in here because I didn't get to see those. Jay, hi Jay, I didn't see you join us. What is the T cell count range to be eligible for this study? Is it relevant as a criteria? Good question. If you got a copy of the CAB draft, I don't know if I forget to put that in there. Usually they have a cell CD4 count. I may have missed putting that in the slides.
I think there was one in the beginning of what your minimum CD4 had to be.
Yeah,
I don't remember what it was.
I don't remember what it was either. If you have one of those CAB drafts, if someone wants to look that up for us, that would be great. So I can just continue on without going all the way back. If not, we will do that. But I think I may have missed it. So basically, use of prohibited medications, bictegravir, emtricitabine, or the new TAF within 7 days prior to entry, or planned use of prohibited medications during the period of study participation. St. John's wort within 7 days prior to entry is acceptable, but it must be discontinued on the day that someone screens. So St. John's wort often interferes with antiretroviral therapy. And so that's the last exclusion criteria that is spelled out in the draft of this protocol that they shared. So this is a list of the schedule of events. So all of the things in that evaluation column is what they will be looking at. And then it tells you whether they're going to be doing it at screening, at entry, during the first 48 weeks. And then you have, after that, the ATI that starts. So this is all the stuff that they're going to be looking at. Let you take a look through these things. That last one, the basically rectal and genital chlamydia and gonorrhea tests is what that stands for. And let me go through the next syphilis testing. You can kind of see these. It's kind of hard to put this large chart all together on slides. So you can see that there's a lot of testing that'll happen during those first 44 weeks that they're going to be looking at. So they'll have a visit.
The bottom one crossed out.
I don't know, because the study team, when they gave us the protocol, it was crossed out.
Well, I wonder if they just made a mistake, because HIV RNA is sort of 1, 2, 3, 4, 5 is the 6th line.
Yeah.
And then the SCA essence or single copy assay is a very highly sensitive HIV RNA.
Right. So it might just be that reason alone. See, if they have the 2 RNA tests, which are the viral load tests, maybe it's just because they put it in there again and they realized it, instead of taking it out of the table, they just crossed it out.
Could be.
Yeah. So it will be collected, obviously, you can see. And then here's the last, where they're going to be storing some things. That leukapheresis that they're doing 4 weeks before the API. They're going to do a reservoir assessment to see where people are after a year of antiretroviral therapy. And
So can you actually do a lipid panel that same day? I don't know the answer.
You're saying right there, week 44?
No, lipid panel has, because you're going to calculate the cardiovascular score,
Right.
you need a lipid panel to do that. And it's screening. So I'm just asking, can you get that the same day?
As the screening. Got it.
Yeah,
Got
because it needs to be part of the screening. And I don't know the answer to that.
So you're wondering if they can do it all in one visit versus having to come back for the lipid panel specifically?
Well, or the lipid panel would need to be done that day.
Right.
Because otherwise you can't give a monoclonal antibody that day if you don't know the lipid panel.
Right. So it looks like that during screening, they would have to do that to be able to continue on with the entry.
Right. So I'm just asking the question,
Right.
Is that something that the lab does?
We will find out. You're wondering specifically about our lab, or are you talking about the ACTG?
Well, or, I mean, you're not going to send it away. You're going
Right.
to have to do it locally.
Do it here, right. I will write that question down. That's a good question. All right, so that's the study in a nutshell. Let me get this. And so what are your thoughts about this study? Comments, questions? Do you think this is something we'd be interested in? Do you think
I know it was late, but besides us or this area, what are the other areas that they're looking at doing the study at?
So mostly domestic sites around the US would be involved in this study. So there was a previous study that was looking to get people who were who were caught. There were other sites that proved that they could enroll people during the acute early phase of HIV. And so those sites would be looked at to enroll this study as well, since they already have the mechanisms and the networking involved to get people enrolled in this study. So that's the plan. And we were one of those sites. I don't know specifically all of the sites that were involved with that previous study, but they were all domestic.
I know that Houston enrolled a lot of people.
Right.
That's what I remember.
So they want to use this study. They want to use the people from the previous study to enroll this study. So that's why they're looking at us as well as the other domestic sites that participated in that previous study.
Do you know how many people they would expect from our site?
Well, considering we had 5 last time, I don't know if they would be expecting 5. So, but we screened 9 and we enrolled 5, which is a pretty good enrollment rate if you think about it, especially given that we're dealing with people who are dealing with finding out that they're HIV positive. There's a lot of things going on. So to have 5 of them actually still choose to get involved in research and to make that decision right then is, I think, pretty good, because, I don't know how I would personally react if I was dealing with all that information and someone was coming up to me asking about a study in addition to all the other things that I would have to be dealing with. But then again, since we're offering them not only the antibodies, we're offering them ART for a year. It could be that people are not sure, like they don't have health insurance, and it might be an easy way to pivot into getting some care immediately until they can figure it out. And also people might be interested in the whole idea of it being able to create post-treatment control. Like what if this study does actually lead to people being able to be off medicine and yet control the virus for an extended time? That would be really great. Camille, you had a question.
You mentioned that this would be very safe. I'm wondering if there are any negative side effects that could occur from this study.
That's a great question. And yes, the analytic treatment interruption is something that could expose people to certain risks. And I know that we have Lori and Corrine on here. What are some of the risks, Lori or Corrine, that people might be facing if they go on an analytic treatment interruption?
Well, certainly if they go on an ATI, their viral load could rebound, so they could get sick, their T cells could fall, they could transmit the virus to somebody else. There's also psychological risk. There could be anxiety, or if you were really hopeful about being able to control the virus and then it comes back, the disappointment of that. So those are some of the risks.
There are definitely risks, and there might be more risks than benefits. I mean,
you were asking about not the ATI, but the antibody, right, Camille? Yeah, so this is about like what toxicity there might be in the antibody.
So the antibodies that were selected, if you look in the protocol that I sent out to you, they were chosen because of their broad powers. They seem to have a wide breadth of HIV that they could address, and they've been given previously to people, and it's been safely given to people. So they don't anticipate many risks related to the antibodies, and we know that the ART is also safe. Go ahead, Michael.
Thank you.
Sure.
Two things. To answer the question that was asked before, the only real reference I see to CD4 count in doing a fairly quick scan of the document you posted is on page 15. It is in the inclusion criteria for step 2.
Okay.
So the initiation of the treatment interruption, CD4 cell count must be greater than 400 cells
400.
per cc.
Thank you.
So yeah, I had put that in the chat.
Yeah, I see that now.
Oh,
too.
I'm sorry.
Thank you. No, don't apologize. Thank
But
you.
not everybody looks at the chat, so it's
Exactly.
probably good that you said something.
Yeah, and so there's probably not a CDR4 count requirement to start the study because someone could technically be having their T cells fall tremendously from their HIV infection. So, I mean, it might be unlikely, but you never know how that might affect. So that's probably why we don't see it for the phase 1 of the study, but for the second phase. You know what I mean? Like once they're on antiretroviral therapy for a year, they have to have a minimum of 400 T cells.
Yeah. I want.
Can't hear you, Lori.
Since you're looking for acute infection, how likely somebody with acute infection would be to have a low CD4 set count as opposed to somebody who may be newly diagnosed but is not acutely infected?
And do you have an answer to that? You did the
Well, yeah, it's unusual, but it can happen. So, and it depends how quickly someone is diagnosed. Sort of the later in that 30-day period, the more likely they are to have a lower count because their viral load may go way, way up.
It also depends on that individual person's immune system too. Because with me, when I was first diagnosed, I had just given birth. 3 months later, I was diagnosed with HIV with T cells up above 700. So, I mean, it also the individual itself, depending on how their body works, their immune system to begin with before they've got HIV too.
Yeah, no, absolutely, you're right, Kate.
So let me move on. I want to try this. These are some of the questions that the ACTG wants me to ask. And so I'm going to launch the first of the poll questions. And you see it there. So if everyone would take a look, the first question is, do you understand the study? And you just get one choice. You can choose yes or no. And the second one is, do you think this answers an important question for the HIV community? So if you would all take a moment and choose an answer. We have 3 people so far. I know there's more than that on the call.
It's not letting me submit.
Okay, I'm not sure why that would be, but
it's not showing me the second question.
Did you
Let me
try scrolling down maybe?
No, it just took me out of it. I don't know. Maybe because I'm on my phone.
Yeah, maybe. So there's 14 of us and I have about 8 people who've answered so far.
Well, I was going to answer the first question, yes, and the second question, you'll have to tell me that one again. And
Okay, the second one is, do you think this is answering an important question for the HIV community? And you can choose yes or no, or you're not sure.
I'm not sure yet.
Okay, I'll mark you down that way. So the other people on the study here, have we all gotten a chance to vote? There's 9 out of 14 of us that have gotten to vote. All right, I'm going to be ending the poll here, and I will share the results with you all. Okay. Does everyone see that? So we had 10 out of 10 saying yes. And the second question with the, is it important to the HIV community? We had 9 out of 10 saying yes and 1 person saying not sure. And then we're going to add you, Kate, to that second one as well. So, all right. So that's the first poll. So get ready. We're going to come up with the second one. All right. Whoops. Let me see. That's not what I want to do there. So let me stop sharing this part here so we can see each other here. All right, so the next question. So the next question I'm about to launch, these next 2. So the questions are, if you were qualified for the study, would you participate in it? And would you recommend others who qualify for this study to participate? So you can start to answer. There's 14 of us. Let's see if we can't get everyone giving us an opinion. Don't be afraid to let us know. I'm going to let it go. We have 14. So far, 11 of us have voted. There's still 3 of us. Don't be shy.
Michael, since I'm an observer rather than a member of your cab, I am
You're
abstaining,
abstaining?
from the
That's
vote.
totally fine, but you're also welcome to vote if you wish.
Yeah, we're pretty flexible, Michael.
Say what?
No, I was talking to the other Michael.
The other Michael, yes.
We're pretty flexible.
Well, if the poll is going to be used to determine a course of action there rather than just, as an opinion poll.
It'll be used as an opinion poll that'll be given to the ACTG just to see what people, it's basically giving them an idea of what people are thinking about the study, the way it's been designed. Do you know what I mean? It would help us a little bit in affecting, our decision, but I think more of the questions that you've given us would affect more of the way we look at enrolling the study or not, rather than just answering these. So this is going to the ACTG, and it's more like feedback to the study team to get them to look at things that they might have to fix or improve upon with the study. So, okay, I'm going to end the poll for this one, and I'm going to share the results with you all. So you can see the first question, if qualified, would you participate? We had about 7 people saying yes, 4 people were unsure, and 1 person said no, which is great. And we also then, for the second question, would you recommend others? Some said yes, about 10 said yes, but we did have 2 people say no. So that's really interesting.
Well, I think 2 people said not sure.
Not sure. Sorry. Yes, they did say not sure. I'm sorry. I misspoke. So next poll question. Do you think people at our site, so this one, Michael, you might not be able to answer, but here's the question. So the first one is, do you think people at our site here in Seattle would participate in this? And do you think that the study benefits are of interest to potential participants? And you can begin to answer these. Up to 10.
So Michael, looking at the protocol, it looks
Yeah.
like the primary objective is about how quickly it gets to undetectable.
Right.
And then more of a secondary objective is the durability and being able to be off art.
Right.
So if people become undetectable within a certain time period, regardless of whether or not there's durable protection later, is that considered a success for the study? And
Well, that would be answering one of the hypotheses questions. I think ultimately the exploratory hypotheses are what really would be probably of more interest to people. In other words, I think with Biktarvy alone, people know that they will become undetectable. And so whether that's happening in 2 weeks versus 4 weeks versus 8 weeks may be of interest to people, but I don't know if they would see that as a benefit necessarily, as opposed to that sort of idea of creating long-term control. But that's my own opinion. I don't know. How do the other people feel about that?
Yeah,
I think the
agree with what you
possibility
said.
that they can do long-term control would be the most attractive,
Yeah,
which is why I'm answering, oh, yes.
cool. Let me share the results of this. I'm going to end the poll here. And let me share these results. So there you can see what people have said. So do you think people at our site, we have a lot more people unsure, about 4. 6 of us said yes. And then would the study benefits be of interest to potential participants? And some said yes. 2 people were unsure. I think these are great answers. Thank you for sharing this. So we have another polling question to go through, and these are going to be a little different. So they're going to actually require you to type in a longer answer. You won't get a yes or no question. So I'll give you a little bit more time. Launching the questions now. And if you will see, there's 2 questions. So the first one is there anything in this study which would discourage enrollment by a specific group? For instance, women or men or people of color, people under 18, people over 50, IV drug users. Do you see anything for any sort of specific subpopulation or key population that lives with HIV that would keep them from enrolling? If you don't see an answer, or if you think the answer is just no, you can write in no. But if you do see a problem for any of these subgroups, please write out that group and tell us what you mean. Why do you think that would be a discouraging question? And then the second one is, do you have any changes that you see to the study that you would like to see made? And that could be anything. If you don't have anything that you see that could be changed, you can write no. Since this involves writing, I'm going to let it last a little bit longer. Okay, let me try this again. Camille, you didn't get the poll. So I'll put the question in the chats for you if you want to try to write an answer that way. I can get it that way. So the first one is there anything in the study?
Yeah, I can answer
Okay.
that. Yeah.
If you want to just put it in the chat, I'll get it. Whether you want to share it with everybody or if you want to send it just to me, either way is fine.
I'll see you next time, Michael.
You leaving, Dan?
Yeah. I'll see you later.
Yes, happy to see you, Dan.
Yeah. Bye-bye.
Bye-bye.
It's good seeing you, Anne.
Thank you. Nice to see you.
See you later.
Wait, waiting for that poll to come in. Michael, I have a quick question.
Yes.
Most people can tolerate, let's see if I can say the word right, Biktarvy.
Biktarvy, yes.
Biktarvy. But there is a small population of people who will run into problems with that.
Mm-hmm.
How will the study deal with that if you have somebody in your study that is not tolerating that?
Good question.
Chances are you're not going to, but there's that slim chance you could.
Yep, that's a good question. I'm writing it down.
And is Biktarvy, is that one that you have to eat with, or is that one that you can take with or without food?
I'm not sure. I'd have to look that up.
Because I know with me, with my medications, I'm not a regular eater, so I don't eat
Mhm.
like meals regularly. And some of the medications where I had to have a certain amount of calories in my system, I had to opt out of taking because I couldn't guarantee I would have that amount of calories in my system.
Right.
So that might be, I should have put that in my answer, but I didn't. But that might be something that might run into a problem with certain people.
You're
I just looked online and it says there are no food requirements for
Cool.
Biktarvy.
I didn't think there were. You know,
I didn't
Biktarvy
think
is one of
so
those
either,
drugs that it can serve a wide swath of people.
Yeah, it mostly depends on whether you take iron or calcium because you can't take it at the same time.
Most of your HIV medications you can't do that with.
Right.
If you take a if you have to take a like a Tums because you got an upset stomach, you have to wait a certain amount of hours.
Yeah, that's Biktarvy is one of those.
Yeah.
Jay, you had a question? I see your hands up.
Yes, I do have a question, or I would like to make a comment.
Sure, please.
About Biktarvy is this that I'm one of those who have reacted with the side effect of insulin resistance. So I have to change my complete renovation of my lifestyle, which means that I'll give you an idea. What I have to deal with every day, every minute of the day is on low carb diet, no sugar diet, and keto diet, and whatnot diet. Basically, I just can't do much of anything, eat much of anything. First of all, on that part, and the other part is just that I am now down to 1 meal a day to be on intermittent fasting so that I can help reducing this resistance, and had to change from Biktarvy to Odefsey, and resulting in rather difficult managing of eating. And for example, last night I went to sleep on Ribelsis, the new medication that is prescribed to me a couple of months ago, and I'm on the double dosing of that. Came to the point that when I go to bed, if I eat after the first meal, which was at 1 o'clock, I would have very upset stomach, intestinal, whatever. And several nights were like that. I go to sleep no later than 7. So at 5 o'clock, I started to have those issues, and I am up several hours in the evening. That is my transition of what is happening with Biktarvy and changing to other medications and the results of that. So in other words, for people like myself, who is already very preoccupied with dealing with something like that, I would say that we will have difficulty, even though we are completely eligible, we will have difficulty getting on another study that is so extensive and so prolonged.
Right.
That's all I have to say.
Thank you for that. Yeah, thank you for sharing that, Jay. It just goes to show you that even when we think things are, widely and well tolerated by a large group of people, there's always going to be someone who's going to have some sort of troubles, and we should never really assume that all people are going to be doing as well on one drug or another drug. Each one of us is unique in that way.
I have another question.
Go ahead, Kate.
You're looking for people who are newly diagnosed and going into the acute stage of it. But are you looking at also trying to figure out if these people have gotten a resistant strain?
Say that again, I'm sorry.
Are you also going to be looking at people that have maybe possibly gotten in contact with a resistant strain? So they came in contact with somebody who had it, but it has never been on their medications regularly, so they built up a lot of resistance to the medications?
Right.
Are you going to be looking for that too, and is that going to leave those people out of the study?
Well, it could potentially lead them into, the antibodies not working or the drug not working, which would mean that by the time they got to the ATI, they would be not able to continue on. So it is possible for people to have not only drug-resistant virus, even though it might be rare, you can have virus that is already sort of resistant to the antibodies. In other words, people can have antibodies or the antibodies won't work for them because they're already sort of, to use a better way of saying, or not a great way of saying it, is antibody resistant virus. So you definitely are hitting on something there that would be a major thing that could affect someone's continuation throughout the entire study.
Okay, so are you going to still want to enroll people though, that if they have that type of virus?
Yeah, well, they're not going to really know about that, I guess, at the start. So I assume that if someone has some sort of significant drug resistance to Biktarvy, they might not enroll in the study. But that's a great question to pose to the study team as well, because I'm not sure the protocol doesn't answer that specific question for us.
Is there a test
Well-
that could test them to see what type of strain they have, or to find
Yeah.
out if it's resistant to these medications?
Yeah,
Because-
there is a resistance test that, at least in the previous study that looked at acute HIV, was done on the first day, but you don't get the result for a while.
Right.
And I don't remember if the study chart you had that test.
I don't remember either. If it had,
I don't think they did somehow, but
yeah.
Well, isn't it pretty standard practice to draw a genotype, even if you're going to do a rapid initiation of therapy?
yes, it
most
absolutely
clinicians would.
It absolutely is, but the question of whether the research study does it or whether it's done for clinical care, and the more the research study does, the easier it is.
Mm-hmm.
And
Well, I know
think
there for
Biktarvy-
a while they didn't want to do that type of testing because it was such an expensive test, unless it was something that was necessary.
And Biktarvy resistance, I think, is fairly rare. It's more the older drugs that,
It's quite rare. Although
Actually-
the 3TC resistance isn't that unusual, and
yeah.
Actually, I cannot take Biktarvy because of some of the medications that are in it, because I have a resistance built up from when I went off the medications some years back and was off of HIV medications for 3 years. I didn't do it medically. I just did it on my own. So I built up a resistance to certain medications, and when they transferred over to the newer medications and non-toxic ones, the RTAs, it cross-resistance out some of those new medications because of the resistance I had from the old ones that are in these new medications.
I guess, Michael, you could ask if they're going to do any resistance screening, and if that would be an exclusion. Would they use a different medication?
yeah,
Yeah.
I think that's a good question.
Yep, that's what I've already written it down. So, yeah, because I don't know. So Bill had to leave us. So we are at the end of our session here. And so I wanted to thank you all for joining us. Those of you who've made it here with us to the end, thank you very much. I hope you got to learn a little bit more about what's happening in terms of trying to create these post-treatment controllers. The whole idea, I think, ultimately where this is going to. This is just another small step in that, trying to get to a cure with getting some control that doesn't need a daily therapy first. So thank you for participating tonight. I really appreciate so many great questions. I can't wait to share them. Oftentimes we don't have as many questions, but you asked a lot tonight. So give yourselves all a pat on the back, and thank you very much for that. Trevin, great to see you. Everyone, it was just great to see you. Peter, hello. I didn't get to see you beforehand. I'm glad to see you were with us. I hope you have a pleasant evening. And the last thing I would love to just point out to y'all is we have a meeting next month. It'll be February 22nd, always the fourth Tuesday of every month. And you'll be getting my emails that'll be announcing what that's about and what we'll be doing. So thank you all for joining us tonight, and have a pleasant rest of your evening. Take care.
Bye.
Bye-bye.